تفضل.
وعليكم جميعا.
مرحبا دكتور مهدي.
أهلين.
يعطيك العافية.
يعطيك
معك
العافية.
سما من باما.
أهلا سما.
أهلا فيك، إن شاء الله تكون بخير. عملتك أنا كوهوست عشان تعمل شير سكرين من عندك.
ممتاز ممتاز اكسلنت.
أي مشكلة بتقدر تبعت لي يسعدك.
شكرا جزيلا. شكرا.
العفو.
قبل ما أبلش بس تعرفوني عليكم شباب، تبلشوا من جهة، ارفع ايدك بس احكي أسماءكم، حابب أتعرف عليكم.
أنا دياب خلوف ممكن بعض.
معلش الاسم مرة ثانية.
دياب خلوف.
دياب.
محمد عكاوي.
محمد عكاوي.
باسل حبوب.
باسل. بزان.
هشام اسعد.
هشام.
معتصم دويكات.
معتصم.
دكتور سعد زيدان.
أهلا فيكم جميعا. اللي فهمته إنه أنتم كلكم في النجاح تشتغلوا internal medicine residents.
صحيح.
وسنوات مختلفة، سنة أولى سنة ثانية أكثر من سنوات. تمام. أوكي. ممتاز. أنا اسمي مهدي أبو سلامة، consultant rheumatologist and physician. بس خليني أبلش to share slides حتى أحكي لكم، أتأكد إنه technology works. هاي الهيدك دائما. هل بين عندكم slides؟ وهيك لحظة شوي. presentation mode شايفين على السكرين one slide. one slide only. yeah.
صحيح.
تمام. اوكي. هلا أنا consultant rheumatologist, physician. Most of the time I'm rheumatologist, but I do medicine like you once a week or sometimes weekends. I do internal medicine. So based on my interaction with internal medicine trainees or even colleagues who don't do rheumatology, I decided to talk about this, which is vasculitis, in my way, trying to talk about what is helpful for you, what you could apply, rather than talking about the details of vasculitis for rheumatologists. So I wanted to take the perspective of me doing internal medicine and talk about that, and hopefully that will be helpful for you all. I'm more than happy to be interrupted, to be asked questions, or if you prefer, we can go through some questions towards the end. Whatever you like, you can interrupt me or raise your hand and I'm happy to stop. I work in Exeter in the United Kingdom. I'm the head of the Department of Rheumatology, but I'm also the lead for training for internal medicine trainees and registrars in this hospital on behalf of the Southwest of England as well. So before I tell you what I'm going to cover during this talk, I just wanted to share with you a couple of cases. I'd like some interaction. I'd like you to tell me your thoughts, initial thoughts. We can talk about it as a group, just to see what you think about these. How would you approach them based on your experience? And then towards the end, we can go back on these cases and perhaps dissect them together. So the first case that I want to share with you is a 49-year-old man who's a smoker, who presented to the hospital with fever, losing some weight over the last few months, achy in his muscles and his joints. There was no evidence of arthritis, despite his complaint of arthralgia. He's also reporting cough with a few episodes of fresh blood with that. In fact, looking back at his record, he did attend emergency department over the last few months with 2 episodes of epistaxis, where ENT colleagues intervened to treat that. During this presentation to the hospital, his observations, including blood pressure, pulse, saturation, were all fine. His temperature is mildly raised, low-grade fevers on that one. You've requested, or ED already requested some blood tests that are available to you and to us with normocytic anemia, which is new to him, normal platelets, and raised inflammatory markers with a CRP of 93. His renal function and liver function is within normal. Apart from smoking, his past medical history include hypertension, for which he is on ACE inhibitor and he's controlled, and he's had previously surgical repair for inguinal hernia. So I'd like to hear from you. There's nothing right or wrong. What is the diagnosis? Or in fact, what are the possibilities? What differential diagnosis you should consider presented with this case? Any idea, any suggestions?
صراحة في wide range of differential diagnosis. This includes infection like pneumonia, maybe malignancy, smoker, have weight loss and hemolysis. ممكن TB كمان. وكمان ممكن نفكر vasculitis مستعكس ممكن نفكر هذا الشيء. أول شيء بدنا نشوف أول شيء plain radiograph ونشوف شو
ممكن تعلي صوتك لو سمحت شوي. أنا انتبهت إن أنت حكيت infection, malignancy, vasculitis like Wegener's vasculitis, yeah.
ممكن TB كمان, tuberculosis.
Tuberculosis, okay, yeah, okay.
فبنروح أول شيء ل chest X-ray نشوف إذا في infiltration, cavitations.
تمام, okay, okay. Apart from chest X-ray, anything else?
ممكن urine analysis.
Urine analysis. Yeah, exactly. His urine is clear. Yeah, I'll show you his chest X-ray towards the end when we discuss the case again. Yeah, but but all of that is absolutely correct. I mean, your differential diagnosis is spot on. Yes, this talk is about vasculitis, so we have to consider vasculitis. But you are absolutely right. Infection, malignancy should be always considered. I agree with all the initial investigations that you wanted to do. In terms of vasculitis, in that differential, would you request anything else to look into that? Yeah, okay. So what do you expect? Which anchor do you expect to be positive if this is vasculitis?
C anchor.
C anchor, okay. More specifically?
Wegener.
Yeah, in Wegener, which anchor do you expect to be positive?
C anchor.
C anchor, and differential to that, there are a couple of C anchors.
ممكن GBM.
Okay, we'll come back to that, but I like that. All that approach is correct. You're absolutely fine. So let me just present to you the second case, and we will come back to those two cases towards the end of the talk. So the second case is a 61-year-old male. He presented with the similar B symptoms, fever, weight loss, loss of appetite over the last few weeks. He's also describing episodes of abdominal pain, some of them after meals, and also testicular pain. He also told you that he's normally fit and well, but he has been tripping over recently. He had a couple of falls. He tripped over. He said, I was just walking home. There was nothing in my way, and I just tripped over and fell on a couple of occasions. His observations are fine, apart from high blood pressure, as you can see, 216 over 100. Again, you've got some initial blood tests available to you, an element of anemia. His white blood cell count and differential is normal. His CRP is raised. His creatinine is high, you've had urine analysis is already done, showing +1 protein, +3 blood. Now, his previous past medical history, he was abusing IV drugs before. He's no longer doing that. He's being clear with no use of drugs for the last few years. As a consequence of injecting drugs in his groin, he told you that he's had DVT twice in the past, and he's already on lifelong warfarin for that. And again, what are your thoughts? What could be in your differential diagnosis presented with this case?
acute kidney injury with hematuria and hypertension, we are talking with nephritic. I'm going with nephritic.
Okay. Yeah. Okay.
He has a previous IV drug user. Maybe he has endocarditis and a post-infectious glomerulonephritis. Especially he has recurrent DVT despite his warfarin. We can think of inflammatory DVT like Bahjat.
Yeah. Okay. I mean, he hasn't got any features of Behçet, but yeah, I think you're talking about infection should be in the differential as a consequence of, whatever infection is going on. We should be suspicious of that. Yeah, I agree. Anything else? Speak. Polyarteritis nodosa. What goes with that? What makes you be suspicious of PAN?
He has abdominal pain and nephritic kidney injury.
Yeah. Yeah. Okay. Yeah, I like that. Okay. So what investigations would you like here, given the differential diagnosis that you just mentioned? ما سمعت.
Geography.
مرة ثانية.
Angiogram.
Angiogram. What do you mean? Which angiogram?
Microaneurysm, renal cell creation.
Okay. Yeah. Okay. Angiogram. You request angiogram. What do you expect to see in that?
Microaneurysm.
Yeah. Where do you see that? Or where do you expect to see that?
Microaneurysm.
Yeah. Okay. Renal and where else?
Hepatitis B. IV drug user and associated with PAN.
Say it again. Sorry.
Hepatitis C associated with
Hepatitis B. IV drug abuser.
Hepatitis B. Did you say?
Yes.
Who said that?
Hepatitis B.
Yeah. But who said that? Which one? Is it Mu'tasim? Hisham. Okay. Tamam. Okay. Mumtaz. We will go back to this case. Excellent. I like this. I like your approach to it, and it's all correct, I can say. Okay. We will come back to that. So. Just to show you, this is, by the way, when you look at his leg, this is not his picture, but I just wanted to get similar picture to his presentation. This is Perbury crash that was down his lower limbs with evidence of neuropathy as well. So, based on those two cases, and as I told you, what is relevant to you, I wanted to talk about secondary vasculitis. I wanted to talk about what mimics vasculitis. I don't want to bother you by the details of primary vasculitis classification. You'd leave that to the rheumatologist, but I wanted to talk about what could be presenting as vasculitis, what could be driving vasculitis, and what looks like vasculitis, but it's not, because it is important to differentiate that. Any talk about vasculitis is not complete without showing you this slide. We're all familiar with this slide. We all seen it in our pathology books when we studied pre-med. It's the sort of accepted classification based on the size of the blood vessels involved in vasculitis. So towards the left, the large vessel vasculitis, the commonest of those is giant cell arteritis. That is common in Europe, in the northern hemisphere. I'm not sure how many giant cell arteritis cases you see in Palestine. I believe in the Middle East is less common than Europe. Takayasu is another large vessel vasculitis in the younger age group compared to GCA. But the small vessel vasculitis, the ANCA-associated vasculitis, is an important one, similar to what we've just discussed already, MPA, GPA or Wegener's, Church-Strauss, which is EGBA. They've changed the names over the last few years to move away from Wegener and Church-Strauss. and also medium blood vessels and other types of immune complex small vessel vasculitis. So the classification based on a size, also coupled with the anchor test, is the widely accepted classification that sort of forms the basis of so many classification criteria out there when it comes to primary systemic vasculitis, as already showed you on the previous slide. So these are the principles of primary vasculitis. I am sure you all come across different classification criteria for systemic vasculitis. There are different ones of them out there, different definitions by the American College of Rheumatology, European League Against Rheumatism, and CHCC, Chapel Hill Consensus Conference classification criteria. They've done so many or developed so many criteria over the years, but how to apply them in real life, how to apply them in our practice is slightly difficult. You know, you can't be rigid about applying those, and there are limitations. For example, I can give you an example of how these classification criteria differ from each other, and the application of those is limited. They took around 100 patients with different forms of vasculitis and tried to apply different forms of definitions, the CHCC on the left and the American College of Rheumatology, ACR, on the right. And these are the same patients, and you can see how in one classification criteria you can distinguish clearly between different sets of patients, but on the other, there is an overlap. That tells you that you don't need to be just fixed or rigid around certain criteria. You have to widen your thinking about it and sort of applying those with taking consideration other secondary causes of vasculitis. So moving on from what is called primary systemic vasculitis, let's talk in details about different forms of secondary vasculitis. Why is it important? Does it matter whether you are facing polyarteritis nodosa case or polyarteritis nodosa secondary to hepatitis B, as you said? Is it relevant? It is, because the treatment is slightly different. As you know, the main principle of treating vasculitis, or pretty much all autoimmune conditions that we deal with in rheumatology, the main principle is immunosuppression. So you'd want to know if there is an active infection involved. You'd want to know if there is malignancy. You'd want to know if there is something, a drug is driving what you are facing, which is similar to vasculitis. So you can, you know, if you immunosuppress them, you can lead to unnecessary morbidity. So it is important to know that. There are different infections and other conditions that can mimic vasculitis, different infections like bacterial, viral, TB, cholesterol embolism, infective endocarditis, myxoma, fibromuscular dysplasia leading to aneurysm. A lot of these conditions, they present like different forms of vasculitis. So I'll sort of expand more on some infections that are important to know, that they can cause vasculitis and induce vasculitis. How do infections lead to vasculitis? There are different theories out there, either by direct toxicity to the endothelium from the microorganisms involved, or the toxins of such microorganisms to the endothelium, or even the immune-mediated response, the body, your immune system trying to fight this infection and sort of inducing this systemic vasculitis picture. Don't forget, it's an opportunity to remind you all that infection itself can be a result of the immunosuppression that we give those patients with primary vasculitis. To mitigate that risk, we do screen for infections. We do put patients on certain antibiotics prophylactically to prevent those infections with protocols for treatment of vasculitis. This just gives you an overview of different types of infections and microorganisms that can lead to large vessel vasculitis or medium vessel or small vessel vasculitis. You can see on the right the types of infection: bacterial, staph, salmonella, mycobacterium. There's been a shift in the microorganisms over the many years. More atypical infections now are causing vasculitis rather than what was 70 years ago, which is staph and strep. Viral, we will talk about that. I'll expand more on that in the next few slides. Hepatitis B and C are leading those infections, in addition to HIV as a common one over the last 30 years or so. Now, in terms of viral infections, as we all know, the principles of dealing with viral infection, we all understand there are three consequences, possible consequences to any viral infection. Either you treat that and your body clear that completely, or that leaves you with periodic reactivation, like infections with herpes zoster, or persistent viral replication, this chronicity, like hepatitis B and C. Now, I'll talk about hepatitis B. As you suggested quite rightly in the second case that I showed you, hepatitis B has been associated with PAN, polyarteritis nodosa, for many, many years, for 50 years. In fact, when you look at the demography and different epidemiological studies, hepatitis B infection were in areas where the hepatitis B was endemic, 95% of PAN cases were positive for HIV. Now, that has changed. That dropped. In a French study, as you can see in the bottom, they compared the positivity of hepatitis B in PAN cases and compared it. In the 70s, it was 38% and dropped by the millennium to 17%. That is as a result of vaccination, as a result of treatments for hepatitis B, and the shift in the prevalence of such infection. Hence, the shift in how many of these are positive in polyarteritis nodosa. So I would suggest that we should always check hepatitis B in cases presented to you with polyarteritis nodosa to identify that, and also if you detect any chronic cases to mitigate the risk before you put them in immunosuppression. Clinically, is there a difference between hepatitis B associated PAN or classic primary PAN? In general, the presentation is similar. However, different studies suggested that you see more gastrointestinal symptoms in hepatitis B PAN and more polyneuropathy and malignant hypertension and renal disease. Just to remind you, ANCA is negative, obviously, in this type of vasculitis. Typical angiography will show microaneurysms in celiac and renal vascular bed. Usually, an infection is being suggested that will lead to polyarteritis nodosa within 1 year of the infection. Treatment-wise, how do we treat those? We all know that we suppress vasculitis with steroids and different regimens like cyclophosphamide, rituximab, etc., etc. When you detect hepatitis B to be a cause of that, you need to consider antiviral drugs. And different studies looked into different regimens, and this protocol is being identified as the preferred protocol using lamivudine combined with plasma exchange to get rid of your immune complexes, combined with short courses of steroids to suppress the vasculitis itself. It has been successful. Only 6% of the cases relapse with this regimen, so it's been accepted and widely used. I hope that's all right so far. Again, if you have any questions, please ask. We'll move swiftly to hepatitis C. Hepatitis C has been strongly associated with cryoglobulinemia vasculitis. In fact, 80 to 90% of cases with this type of vasculitis are associated with hepatitis C antibodies. So it goes without saying, you know, that it is important to screen for that and identify this relationship early on. because of the impact on treatment regimens that you want to consider. Clinically, how can you differentiate? In general, cryoglobulinemia, whether hepatitis C associated or not, present in similar way. However, they identify its most common feature is purpuric rash, probably similar to the case that or the picture that I showed you earlier on. Livido rash, necrosis, ulcers, leg ulcers, arthritis, and polyneuropathy. The most useful test that will help you to differentiate between primary cryoglobulinemia vasculitis or hepatitis C1 is checking complement level. You get low complement level in the one associated with hepatitis C in 90% of those, in association also with rheumatoid factor in 70%. If you want to ask for test, probably complement is the most important one, in addition to obviously negative ANCA, as I said earlier on. Both, whether hepatitis C associated or classic cryoglobulinemia, they can cause renal disease. Biopsy will help you, where in biopsy with hepatitis C1, you will see different form of thrombosis within the vascular microvessels. Treatment-wise, the introduction in general of direct antivirals has shifted the prognosis, leading to better prognosis when treating those with hepatitis C-associated cryoglobulinemia. I won't talk about other infections in details. This table probably summarizes, in addition to what I've mentioned about hepatitis B and C, HIV, parvovirus 19, varicella zoster, and CMV. Couple of points about each one. In HIV, the treatment, when it comes to treatment, there is no widely accepted treatment. There is no single study that will show that one approach is better than the other. In general, you'd want to use short courses of steroids in addition to treating the HIV with antivirals. In parvovirus B19, they can be associated with something like polyarteritis nodosa, but the commonest presentation is probably like IgA vasculitis. Again, treatment with short courses of steroids is advised. Moving on from viral to bacterial infections, as I told you, there's been a shift in the spectrum of bacteria associated with vasculitis. It's changed over the last 30 years or so, from typical strep and staph to more unusual infections, for example, Mycobacterium, Enterobacteria, and Salmonella. In 50% of the cases, you'd be able to identify the bug on blood culture. On some, if you're presenting with skin manifestations, a skin biopsy can identify the microorganisms within the biopsy. Here, I listed few predisposing conditions like previous injection of drugs, hypertension, diabetes with the effect on the immune system, and myelodysplasia syndrome. They can all predispose for these. Couple of points about Mycobacteria. It can affect any blood vessel when it induces vasculitis. It seems that veins more often involved than arteries from the histopathology studies that were done on Mycobacterium-induced vasculitis. Different form, whether large, medium, or small vessels being implicated with Mycobacteria, and one of the commonest skin manifestations is erythema nodosum. And again, biopsy from these lesions can identify, very rarely, not all of them, acid-fast bacilli in those. Couple of things about when you're talking about secondary vasculitis, about vasculitis and malignancy. I've digged into the latest studies about this. I've presented to you here a couple of things, just highlighting there are differences in what's out there. One study above there suggests that malignancy, the rate of malignancy simply increased with vasculitis, primary vasculitis, compared to normal population, while the bottom one from Denmark did not demonstrate any association between the rate of malignancy and the presence of vasculitis. So conflicting data out there. I think we have to obviously screen for vasculitis, have a low threshold to investigate for that. And we certainly get different referrals from oncology, raising the question about the development of vasculitis. One of the things that I want to highlight to you, and again, that's something you maybe take note of. I don't know how much you know about immunotherapy in oncology, but immunotherapy over the last few years has caused a positive shift in the survival of certain malignancies. You're talking about melanoma, from cancers of melanoma that would kill you within 6 months. Now with immunotherapy, you're talking about 5, 6, 7, or 8 years survival. However, the price of such therapies, immunotherapies, has come with the development of secondary immune-mediated conditions, ranging from true rheumatoid arthritis, vasculitis, lupus, even Crohn's or ulcerative colitis. So be careful of that. Always be suspicious of it when you're dealing with someone with already cancer on immunotherapy presenting to you with immune-mediated conditions. That's a different talk altogether, the immunotherapy, and it's wide, but I just wanted to mention that to make you aware of it. This is just really a table that will summarize certain conditions that may be associated with the subsequent development of vasculitis, whether lymphoma or myeloma or myelodysplasia. And on the middle here, you can see the different types of vasculitis that been implicated in that, based on Cochrane review involving just under 3,000 patients that I came across when I looked into this for you. This slide only is just about drug-induced vasculitis. This is an entity, again, as internal medicine specialist and future consultant physicians, you should be aware of it. Different drugs has been reported. There are numerous case reports out there rather than sort of larger studies. Just listed few drugs there that have been really reported to cause vasculitis or vasculitis-like presentations. It is difficult really to establish a cause relationship. I think these case reports just highlight some association, but whether the drug caused the vasculitis or not, I think that is difficult to prove, difficult to be certain of. This slide is just to remind you basically with what I was just saying about what mimics vasculitis. Infections toward the top, we did talk in the last few slides about certain infections presenting with vasculitis, inducing vasculitis. We talked about the relationship with malignancy. Then we did mention certain conditions, whether embolic or thrombotic, that present with what looks like vasculitis, and in addition to aneurysmal conditions towards the bottom there. So this is important slide really, just to remind you of the conditions that could present to you with vasculitis, but in reality, it is not vasculitis. That is different from what I talked about when secondary vasculitis happens as a consequence of infection. These are not vasculitis, these mimics of vasculitis. So we're almost there. I just wanted to go back to the cases. You all mentioned all the right things about the differential diagnosis in this man who presented to you with symptoms which could suggest infection or malignancy, but you quite rightly suggested Wegener's because of the epistaxis, because of the hemoptysis in him, and that should be considered. So you should request ANCA. You'd expect to see C-ANCA positivity. In Wegener's, you'd see that as a PR3 as opposed to MPO vasculitis positivity. You'd want a biopsy. Ideally, you'd want a biopsy to confirm vasculitis. And the common one to ask for here is nasal biopsy, which will show probably granulomatous changes to confirm that your suspicion of Wegener is correct here. But I agree, you have to rule out infection, you have to rule out malignancy. He's a smoker, so he's at risk of that as well. So in this case, this is his X-ray. Can you see all the X-ray? Is it projecting clear to you?
Yes.
Would anybody comment on that? What do you think of the X-ray?
In bilateral nodules, maybe it's just a cavitar region, especially in the right side, right middle zone.
Yeah, I agree. Yeah, would that help you in the differential? We've mentioned infection, malignancy, and Wegener. Would the X-ray help you at this stage, or would it still be within those three different?
Region can suggest malignancies, can suggest infection, can suggest Wegener.
Yeah.
Confirm diagnosis or further imaging CT scan or such that.
Yeah, I think you're right. Further imaging. I mean, the multiple nodules may suggest it's, unless this is a metastatic disease, probably you're talking about pushing Wegener towards the top or atypical infection rather than primary malignancy of the lung. But, you know, it's further imaging will help you in that. So that was a case of Wegener's. I agree with all of you. Again, just to prove the point that there are different classification criteria, but this guy, this patient, will probably tick the box here in terms of if you want to apply the classification or different diagnosis criteria for Wegener's, which is granulomatosis with polyangiitis. He's got nasal involvement. He's got abnormal chest X-ray, as we've just described together. Although his urine dip is clear, a biopsy will clinch the diagnosis in his case, a nasal biopsy, and then you move swiftly to treatment with immunosuppression. The second case, just to remind you, he's presenting to you with possibility, again, malignancy infection, but one of you mentioned polyarteritis nodosa here should be in the differential, and I agree completely with the abdominal pain, with the testicular pain, with the acute kidney injury and positive urine dip and blood, and the previous history of IV drug abuse. And that is a classic presentation of PAN, but in this case, hepatitis B is the driving force for this illness. So to identify, in this case, hepatitis B associated PAN is important, as I explained to you, because the treatment would involve giving him antiviral therapy. Just a quick question to you. What do you think of +3 blood in his urine dip? What do you expect that in polyarteritis nodosa?
I think yes, because of there is glomerular disease, vasculitis, glomerular injury.
The first part of your answer is correct. Yes, you'd expect to see blood. The second part probably not accurate. In fact, you'd want to if you want to differentiate, if you want to go to the nitty-gritty and differentiate whether this hematuria is due to PAN or ANCA-associated vasculitis, the difference is in involvement of glomerular membranes or not. The glomerular disease is C-ANCA vasculitis, is not PAN. In PAN, the hematuria is usually and most commonly as a result of ruptures of microaneurysms within the renal blood vessels. So to differentiate, there is probably a very quick bedside test that will help you to differentiate between the two. Can you think of that?
Small-thick RBCs.
Say it again.
Small-thick RBCs.
Sorry, I didn't get that.
Small-thick RBCs by microscopic examination of the urine sample.
Yeah. What do you look for again?
Dysmorphic RBCs.
Dysmorphic. Yeah, I think you are on the money there. I think you're right. I mean, so you ask the lab to check for the presence of RBC casts to differentiate whether this is a glomerular disease or microaneurysm rupture in PAN. So yeah, well done. So that, I think, pretty much what I wanted to say. This is a slide just to show you extensive classification criteria for PAN. I just wanted to put this up. You don't need to know this table to think of PAN. We've already established that. You've suggested it in the differential when I first presented the case to you, and I would encourage you to continue doing the same. I don't think you should go back to a book or a table like this and say, "Oh, actually, how many of these? Can I take 10 of those to confirm whether the patient in front of me has got PAN or not?" You may have 1 or 2 of these, and a friendly radiologist doing angiogram for you, and you've got the diagnosis. So yes, it's important to be aware of different classification criteria. Maybe you'll get asked about it in your exams, whether clinical or written. I don't know how many questions you get in rheumatology in your exams, but in clinical practice, probably should be aware of it, but not be rigid about applying these criteria. That's all I want to say. Thank you very much for the interaction with me, and I'm happy to take any questions that you may have.
Thank you.
Are you happy with that? Yeah?
اكيد طبعا. يعني يا ريت لو يكون في كمان محاضرات ثانيه.
يا سيدي انا على راسي، ان شاء الله ان شاء الله ان شاء الله. بتمنى انه انتم يعني استفدتوا من الاوفر فيو، بتمنى انها تكون ريليفنت ليون اون براكتس، وان شاء الله بنلتقي في مرات ثانيه ان شاء الله.
ان شاء الله.
شكرا جزيلا، موفقين جميعا، موفقين.
يعطيك العافيه.
والعافيه. مع السلامه.